The American Brain Tumor Association is pleased to welcome you to our webinar series. My name is Bree Salzman, and I'm a program manager here at the ABTA. I want to send a big thank you right away to today's webinar sponsor, Chimerix, for their support of this program. As a quick disclaimer, the American Brain Tumor Association provides this information as a service. Information provided by the ABTA is not substitute for medical advice, diagnosis, treatment, or other healthcare services. This information is not intended to replace discussions with your physician, and the ABTA strongly suggests consulting your doctor or other healthcare professionals regarding your particular needs. I am really excited for today's topic, Understanding Diffuse Midline Glioma, a guide for patients and families. Our speakers today come with a wealth of experience. Dr. Koshman is a pediatric neuro-oncologist in the Department of Pediatrics at the Chad Carr Pediatric Brain Tumor Center and the clinical research director at the University of Michigan. Talk about a title there. He serves as the co-scientific chair for the Children's Brain Tumor Network and the co-chair of the Diffuse Midline Glioma Working Group in the Pediatric Neuro-Oncology Consortium. Dr. Kochman's lab investigates the molecular mechanisms by which mutations in diffuse midline glioma promote tumor growth and affect response to therapy. Additionally, if that's not enough, he also serves as co-investigator for multiple early phase studies in DMG, for which his lab performs analysis of correlate tumor and cerebrospinal fluid samples. We are also lucky to have a second speaker today, Daniela Ciccolini from Chad Tough Defeat DIPG. Daniela began her career as a nurse practitioner in 2013 while completing a fellowship at St. Jude Children's Research Hospital. Prior to joining Chad Tough, Daniela worked at Boston Children's Hospital as a neuro-oncology nurse practitioner caring for children with cancer, including DMG. She is studying for her doctorate in nursing. Yay! Congratulations, at Northeastern University, and hopes to use her research to improve care for children diagnosed with DMG. Thank you so much to both of you for joining us today, and take it away.
Thanks so much, Bree. I think this is really exciting for me, and I think exciting for Daniela as well to work with ABTA. There's so much new wealth of information about how we understand DMG and how we manage it. And so this is a great chance for us to get that information out to the community and have a good discussion today. I'll go ahead and start sharing my screen. Okay, so we'll just go ahead and get started. So our learning objectives today are presented here. We're going to talk about how to understand how DMG is diagnosed and common signs and symptoms, explore treatment pathways, and as well as discover strategies for managing symptoms, side effects, and maintaining quality of life throughout treatment. On the front end, I'm going to talk really from the narrative of, for a new diagnosed patient, how we think about working up those tumors, what are some of the things we find when we work up a midline glioma, and how that might affect care, and then go into some of the ways in which we treat, things that are standard of care and things that are experimental currently. And then Daniela's gonna, after me, she's gonna present a little bit more on how we support our DMG patients and how we think and manage some of the associated symptoms. So just starting out with the acronyms to make sure we're all on the same page. DIPG, diffuse intrinsic pontine glioma, is actually a term that has been used more historically and continues to be used. And it is a radiographic diagnosis of a tumor that infiltrates the brainstem and fills at least half of the middle part of the brainstem, called the pons. This is a tumor that historically is how we diagnose patients prior to biopsy. And now that we're biopsying tumors, we continue to use this term, especially in ways to link together tumors that are in the brainstem that have this biology. But since 2016, the WHO added this extra acronym and diagnosis called diffuse midline glioma, which pulls together DIPG with regional tumors that are all in the midline of the brain. So if you see this graph here, This is the outside of the brain and the cortex of the brain in gray. And all of the area in purple here is the midline, the thalamus, the brainstem, and the spinal cord. And the reason that those were lumped together is they have very similar biology, shared prognosis, shared subgrouping by various pathology tests we do, but also across this whole spectrum, 2/3 of them carry this histone mutation called H3K27M. And H3K27M is seen in 80% of DIPG and about 2/3 of the tumors overall in the midline glioma. When these tumors are worked up, you can be a midline glioma with or without this mutation. That's important to know. And then DIPG is still now a subtype of DMG. It's just the brainstem DMGs. So this is maybe the most complex slide I'm going to present, but it's a really important one. What is the histone mutation? So histones are proteins that DNA wraps around. And the reason they're so important is they basically tell the DNA within tumor cells how to behave. And so the histone mutation has the ability to have huge impacts on how the cells behave. If the DNA is the book by which the cells, come up with the programs and how they behave, this has basically flipped the book, and it's very different chapters that are being read. The overarching feature is a histone mutation communicates to all of the DNA to behave more like a stem brain cell, more like a baby brain cell, and continue to proliferate. Whereas most cells without this mutation would eventually mature and become adult brain cells and stop dividing. So if you imagine that histone mutation just having a very specific impact, and so the tumor biology is very specific whether you have the histone mutation or not. This is a mutation that's not really found outside of the midline tumors, with rare exception. And so it's something about the developing midline of the brain where this mutation is tolerated and allowed to turn into a tumor. There's nothing that we've found that predisposes any diet or exposure. It's just the risk of developing a brainstem that this mutation occurred. Why it matters is that histone mutant tumors have a little bit worse prognosis than the other midline gliomas and high-grade gliomas that don't have the histone mutation. We'll get into more detail than that, but it's another way in which the mutation really affects the biology, is it makes it a particularly aggressive tumor type. So I'm going to talk about prognosis, but I want to sort of add the caveat that these numbers come from 5, 10, sometimes even 15 years ago. And I think we have a lot of new tools just within the last 10 years. So I always tell families the survival numbers you might see for DIPG and DMG, take them with a grain of salt of our treatments are definitely better than they were. We just don't have a lot of updated survival data with the new therapies. The other piece is each patient is different. So this is, having an average survival for a diagnosis is helpful for a frame of reference, but it doesn't tell us with like any high level of accuracy exactly how each individual patient is going to be treated and how long the tumor will go before regrowing. But with that in mind, the historical median overall survival for DIPG is only 12 months, and for thalamic midline glioma is closer to 14 months. Radiation therapy is the standard of care, and that is offered at virtually every institution. 6 weeks up front, we do say that that should be standard of care. Radiation therapy has enough data now across multiple sites and is being used uniformly enough that it's getting close to consideration as standard of care. And what that means is reirradiating the tumor for 2 weeks if it's been at least 6 months from the initial radiation. Again, some cases are more or less amenable to that, but I just mentioned that as something approximating a standard of care. If we just think about why to biopsy, one is to confirm that histone mutation. One of the things that some groups have shown is that atypical DIPGs, basically it's not purely in the brainstem, it's maybe not in the middle part of the brainstem. Some series have shown that up to 1/3 of those are not typical DMGs, they're other tumor types. And we've found at our center that even 10% of typical radiographic DIPGs end up being another tumor type. So that is a reason to biopsy to confirm the tumor type. and also to look at other genetics. We'll talk about why those matter. And then increasingly, you'll see in clinical trials that we're doing trials where we're saying, you're going to get the drug that we think might help your tumor. We're going to start it before your biopsy to see if the drug gets into the tumor. So we know, if it's working, why it's working, and if it's not working, why it's not working. Why do we care about other mutations? One of the things that our group show is that when we looked at patients who were long-term survivors of midline glioma, and by that we said patients longer than 3 years from diagnosis, which was enough different from the average to look at a group of about 50 patients. And in those patients, we found one of the main signatures was that they carried additional mutations in a pathway called MAP kinase. So that's another thing that a biopsy would help tell you is, do you have the histone mutation, but also do you have a second mutation in this pathway called MAP kinase? The most common of those is BRAF. The other mutations are FGFR is another one. And what we found is that for that subgroup, they do well, or they do better than typical midline gliomas, kind of regardless of what they're treated with. Some of them were treated with ONC201, some of them were treated with other things. And so this is important prognostic information to know from the biopsy. So just starting to move forward into how do we treat these tumors, I'm going to break this down into 3 groups. One is targeted therapy, and we're going to spend some time talking about ONC201 because of its recent FDA approval, immunotherapy, and then sort of other. And I really base this around, what do my families ask me about? And so I really want to talk about some of those other experimental therapies that come up a lot. So ONC201, just to start with, is a drug that's taken by mouth. It's designed to target dopamine receptors. And again, this is a busy slide, but what was found in an adult study in non-midline gliomas is that the drug was safe and got into the brain reasonably well in a good way, but did not necessarily help patients with adult GBM. But there were a few younger patients who had the histone mutation who did better than expected. And so we and others built out this phase 1 and 2 trial in just that patient population. And that has led to some of the data that has supported its use in so many patients with midline glioma. Importantly, the drug also goes into the tumor cells and affects the mitochondria, the gas tank of cells. And we think that's actually probably the more important mechanism of action for K27M tumors. This is, again, a busy scientific slide, but I think it's an important one to show why we think the drug is working in K27M cells. When the tumor goes in and disrupts the mitochondria, it changes the metabolites and epigenetics of the tumor to restore these precursor type midline glioma cells to be more genetically like differentiated brain cells. And the way we see that is, what happens with this stain H3K27 trimethyl, which is a different stain, which is generally low in our histone mutant tumors. And with ONC201, it goes back up to normal. And that being low on the K27 trimethyl is a very unique finding to K27M tumors. And it's one of the reasons why the focus so far has been on those tumors. Even when we look at patients who were treated with ONC201, this is what that K27 trimethyl stain looks like over here, up here. And patients who got ONC201, that was restored. And this looks a little bit more like normal brain. So it's an important finding that was supportive of this drug having on-target effect in brain tumors that had this histone mutation. So this is the schema we use. I'll just explain this very briefly. ONC201 goes in, disrupts the mitochondria. Those metabolites affect the genetics of the cell, and they basically make the cells have more of this increased trimethylation, which drops what we call the H3K27 transcriptional program. Confusing, scientific, but really important, we think, and one of the things that's helped us think about how we're going to monitor which patients might respond, which tumors might be amenable, and what drugs we might want to combine with ONC201. When we start to think about where is it at in the clinic, it's being studied by itself and in combination in a number of trials and around the world. This was the key study, which was published by some of our adult colleagues, where they looked at thalamic midline gliomas with K27M, and they found that about 20% of those, these were all recurrent patients whose tumor had already grown, had a radiographic response. And that was enough, that data, and as well as how well the drug was tolerated, and some of the mechanism that we just showed were enough for the FDA to approve this as the first FDA approval for H3K27 DMG. And that approval does include children and brainstem tumors, as long as they have the histone mutation and they're at the recurrent setting. And this is obviously in the US only at this point. So where do we go from here? So this was a big step because it was the first FDA approval for any systemic therapy in DMG. The clinical data is promising, and we do have a small portion across all of these sort of various smaller studies that are longer-term survivors with ONC. The mechanism itself is very novel, and the drug is very well tolerated. So all of these are sort of in the camp of pro for ONC201. There are a lot of things we still need to know. This was an approval that was what they called accelerated. And what that means is there needs to be some follow-up studies to show that that early small data set is seen across larger, bigger, better designed trials. And so that is, that main study is called ACTION. It's a phase 3 randomized trial that's ongoing outside of the US. We also need to figure out which patients may respond to ONC so that we can say, you're a patient that might do better with ONC and you're a patient that might not. Let's put you on this therapy or that therapy. Those things are still being sorted out. Just in terms of how might we do that, our lab is very focused on a specific pathway of resistance to ONC201 called EGFR. And EGFR is a pathway that is activated by mutation or upregulation in a lot of brain tumors. But what we found in looking at our early cohorts of patients treated with ONC201 is that patients who had EGFR mutations didn't do well with ONC201. And this is a small series, but really we found that across all the tumors, the less EGFR activity you had, the more likely you were to have a radiographic response. And in fact, the adult group that has histone wild-type glioblastoma, which is sort of the high-grade tumor out in the cortex that adults see, they also found that EGFR activity predicted resistance. So we think something is going on where EGFR makes these tumor cells less sensitive to ONC201. So we're working on the mechanism of this, as well as some drugs that we're working on in our lab and with some collaborators that might help address that mechanism of resistance or that ability to make tumors with high EGFR also have this potential response to ONC201. Other ONC201-based trials, this PNOC22 trial, which is really a platform trial where drugs are added in combination, and so far those have been with ONC201. There are, right now, if your tumor has a mutation in one of these pathways, you may be eligible for getting ONC201 with the drug that targets that extra mutation. Those studies are ongoing. Avapritinib is a drug that we had previously showed, along with some collaborators, is very promising for targeting PDGFRA, as it has good brain penetration and can knock down this pathway PDGFRA. ONC206 is a modified version of ONC201 that is still in phase 1 study, and it was modified to get into the brain better. And our preliminary data and the published data from collaborators has shown that it actually works a little better than 201. We don't have clinical data yet to make a comparison head-to-head, and the goal dose is still being determined, but that phase 1 trial is underway. We move on to immunotherapy. We're going to start with CAR T. That is the big potential treatment for DMG that gets a lot of focus. And by immunotherapy, we mean encouraging the immune system within the body to find the midline glioma and actually kill the tumor cells. So CAR T is chimeric antigen receptor T cell, and basically it means taking T cells from a patient, modifying them to find the tumor, and then infusing them. In the early studies, it was in the blood, but most of the ongoing studies, it's being infused into catheters that basically locate the T cells into the ventricles and drain around the tumor. And with that, both the Stanford group, which I'm showing data here, and the Seattle group, which have published large series on this, have shown that a subportion of patients who get CAR T have not only a radiographic response, but also clinical responses And some of these clinical responses that have been published are a little bit sort of more quick and dramatic than some of the sort of slower but steady responses that we've seen sometimes with ONC201. Not all patients respond to CAR T, and so the current clinical trials are, can we improve upon those early studies, either by adding chemotherapy, and the chemotherapy would be there to reduce the body's immune system to allow the T cells to work fully, or by improving what targets in the tumor are there. And those are unanswered questions. These are the ongoing studies that are occurring with CAR T for DMG. This is the trial that we've opened here, which was originally started at City of Hope and targets a different protein, IL-13RA2. And this is an example of how chemotherapy is given. This patient is admitted for their first cycle. They get chemotherapy that's there to reduce that immune system within the patient. Then they get infusions for that first cycle in their Ommaya. And then they get them as an inpatient or as an outpatient without chemotherapy in subsequent cycles. Moving on to another type of immune therapy, this is an oncolytic virus that was led by Dr. Marta Alonso in Spain and her team. They did a phase 1 in 12 patients, and they saw a promising survival outcome in that small series of patients. That is going to be opened, we think, maybe late this year, early 2026, across a few sites in the US and Europe. And in that case, we're going to do the virus on multiple different infusions into the brainstem. The virus there infects the tumor cells and kills them selectively. And so this hopefully builds upon that early success by doing the virus injection more frequently. Moving on to other potential therapies. Kepra, you may have heard, this is a new field of science that's really been led by Dr. Michelle Monge at Stanford. And the idea is midline gliomas infiltrate into normal brain. Those neurons, which are electrically active cells in our brain, are fully interwoven with the tumor cells. And what Dr. Monge has shown is that those neurons actually form synapses with the tumor cells, with the midline glioma cells, and support the tumor cells, help them grow. And so depending on the pathways that are active, what Dr. Monge has shown is that Kepra can modify some of that signaling. And this is a very well used anti-seizure medicine in clinic. And some of our patients with midline glioma are on it anyway to prevent seizures. We don't yet have clinical trial data to show that this should be used as a standard of care. But retrospectively, our data between U of M and Stanford has shown that patients on Kepra did do a little better. We would need to study this in clinical trial to confirm that this is the case. But interesting potential consideration to discuss with your physician. And then CBD, this comes up a lot, and patients have asked me about it for so long that our lab ultimately studied it. And we were surprised to see that CBD does slow the migration, basically how midline glioma cells. This is a scratch assay, right? So these are midline glioma cells on a plate. You scratch a little blank spot for them to fill in, and the midline glioma cells grow right into that space. They migrate the way they do in the brain. With CBD at high doses, we found that migration does really get reduced. And in mouse tumors, CBD can slow the tumor, not dramatically, but to a small extent, and reduce some of that migration. And so we do, again, short of standard of care, we need a clinical trial to show that this is helpful. But for my families that are motivated to take CBD, I do say we should consider using higher dose, similar to what's used for pharmaceutical grade CBD, which is a drug called Epidiolex, to be able to get that migration effect. This may impact the metabolism of other drugs. It may affect the immune system. So again, you just need to discuss this with your provider, especially if you're on a clinical trial. That's the end of my portion. This is my wonderful lab who does all the science that I was able to talk about, and some of the collaborators, all the amazing funding sources who have supported this work. I am going to stop sharing. Daniela is going to take over and talk about some of the other aspects of DMG care, and I'll obviously stay on the line for questions.
Thank you so much, Dr. Koshman. So my portion is really to just talk about the day to day. When you have a diagnosis of a DMG, or if you're supporting someone that you love or care for with a diagnosis of DMG, how do you make the most of every day? How do you feel as good as possible with this diagnosis? And what are some of the more common symptoms that we do see that we can help to troubleshoot or better understand? Okay, so I think continuing on what Dr. Koshman was saying, I do think it's important to understand that the biology of this very unique type of tumor does inform the actual symptoms that we see in patients. And what that looks like can vary because of its location, but it is all related to the fact that this tumor occurs in the brainstem. The brainstem is arguably one of the most primitive parts of our brain. It is the most primitive parts of our brain, and it's where all of our vital functions originate from. It's where our thinking about our vision, not our thinking. It's about our vision, our hearing, our basic motor functions, our speaking, our swallowing, and even our heart rates and our breathing. So it's such a sensitive area of the brain. And so we tend to see the same constellation in many symptoms, but within that, there can be some variation depending on which exact parts are affected. We see the symptoms occur at diagnosis typically, and then for majority of patients, if they are able to receive radiation, and if the radiation treats the tumor in the way that we hope, they then have some relief from those symptoms during the radiation phase. And then inevitably at some point, which as Dr. Koshman alluded to, the therapeutics we have to offer in the form of these clinical trials are delaying this, but progression does occur. And that is typically when we start to see a recurrence of either the same symptoms seen at diagnosis, or sometimes new symptoms plus some of those symptoms, or new symptoms altogether, depending on the location of tumor growth. The symptoms are also correlated to the amount of pressure and swelling caused by the tumor or by the treatments that we give. There are some treatments, like that CAR-T trial, that can create a tremendous amount of swelling in the brain that needs to be carefully controlled and can cause significant neurological symptoms. So these common symptoms that I was referring to, the most predominant are these six. You see nausea and vomiting related to that increased pressure, or from some of these therapeutics that we offer. Most patients during their radiation develop nausea to some extent. Headaches are a very common presenting symptom, as well as persistent symptom depending on the particular patient. And that is again related to the pressure changes in the brain. Speech changes. We can see slurred speech, difficulty with word articulation, enunciation, swallowing impairments. And so parents will tell us that one of maybe the first signs that they noticed was they saw their child maybe choking when they were attempting to eat, or sputtering a little bit when they were drinking a liquid. Visual changes, that's also a primary presenting symptom for many families, that the first thing they noticed is maybe there's inward deviation of the eye, or a complaint of seeing funny, which could translate to double vision, is very common, as well as a drooping eyelid. And then difficulty with balance or coordination. I've seen examples of a patient having difficulty in a sports activity and end up with an injury and receive a scan and come to find out they had a diffuse midline glioma. So let's talk about headaches. So managing headaches, as I already mentioned, the headaches in particular are correlated with that increased pressure from the tumor growth. So in a person that is older than the infancy stage, once those soft spots in the top and in the back close, you essentially have a contained space with the skull, the membranes that cover the brain. And so what can happen is as this tumor develops and grows larger and larger, it creates an internal pressure on the sensitive brain tissue itself, creating the headache. It's very much a space issue in that regard. You also, from the activity of the tumor, the spread of the tumor, the irritation from the tumor to the brain tissue, you can get a buildup of fluid in the brain, which is termed hydrocephalus, and patients sometimes do need a shunt placed for that. And then the brain swelling itself. Our brains do not like anything that is foreign touching them, anything like blood, tumors, fluid, anything that is directly touching that brain tissue that is in a space that should normally be free of any artificial substance or atypical substance, causes a lot of swelling and irritation. So the brain itself swells. How do we manage this? The primary management for these types of headaches is actually steroids. It's dexamethasone, which reduces that brain swelling and that pressure. Understandably, many patients and families want to be on the least amount of steroids for as short of a time as possible, and that is generally the goal of care. There does come a point, though, where if the steroids are not initiated, we start worrying about vital functions of the patient and in an emergency capacity. And so sometimes it is quite urgent to initiate them. Excuse me. Sorry. Elevation of the head. So keeping your head up about 30 degrees, especially during sleep, it can be helpful. So just if you're at home, propping up with a couple of pillows, sleeping on somewhat of an incline can help reduce the pressure, because the more upright you are, the less pressure is on the brain. Pain medication. You can work with your pain team. Tylenol is usually the first line beyond the steroids, but sometimes if the headache is severe or persistent enough, opioids are necessary in certain circumstances. In general, ibuprofen or the NSAIDs are avoided because of the risk for bleeding, as well as just trying to follow patterns. What makes your headache worse or better? Does caffeine help, or do you end up with mid-afternoon rebound headache, and maybe that's not the best approach? How much sleep are you getting? How much are you exerting yourself? How hydrated? There's all those are multifactorial things to consider that can inform headache management in any way that we would normally think about chronic headaches. Nausea and vomiting. So this is also related to the pressure in the brain, as well as sometimes the treatments or the radiation therapy, as I mentioned. We manage this. Zofran is a first-line drug used for this. It can be given intravenously, orally, sublingually, liquid form. It is generally very well tolerated. It can lead to constipation, though. So if you find that you or your loved one's developing any stomach discomfort, troubled stooling, and you've been taking Zofran a couple times a day for a few weeks, you may want to think about that as potentially being causative, and/or working on hydration, movement to try to counteract that. You also can have nausea from some of the treatments. The Modeso, the ONC201 that Dr. Koshman spoke about, can be nauseating to some patients, and that typically does get much better after the first couple of months, but some patients do need nausea medication for that. And then the radiation. Anytime anybody gets radiation to their brain, almost universally, there is some component of nausea with that treatment. Other ways to manage this is frequent small meals. It may sound counterintuitive, but actually keeping a little bit of something in your stomach every couple of hours can be soothing in a nausea context, as well as promoting energy with caloric intake and good hydration. If it becomes an issue where intake becomes less than what would be needed to support a person in their day-to-day, so you may be taking in less than 1,000 calories where normally you would need about 2,000. That's a time to ask your oncology team to get a referral to a dietitian and trend weights and things, where they have a lot of little things that they can recommend to try to increase oral intake without more discomfort. avoiding triggers, strong smells, greasy foods, things that are just generally upsetting to the stomach can be something to avoid. Looking at fresh air, going out for a walk actually is really great for nausea management. Some people get really car sick. So sitting up front, if you're old enough and it's safe enough to do so, opening windows during travel if possible can help. And then timing, we generally suggest taking nausea medicine prior to meals as well as at bedtime. If you're going to take your, say, your ONC201 at bedtime on Monday evenings, you want to take the Zofran maybe about an hour before to try to help reduce the nausea. And then dysphagia or difficulty with swallowing. As I mentioned earlier, this is a symptom that is sometimes one of the first symptoms to notice that may not be quite obvious at the beginning, but then perhaps a couple months after diagnosis, someone may say, "Oh, I noticed that when my child was drinking their apple juice, they seemed to just cough a lot, and I thought they were maybe just getting sick, but I think maybe it actually was the tumor." This is something that we take very seriously. We want to make sure that that the food is going down the esophagus into the stomach, not accidentally into the trachea, into the lungs, where you can develop a pneumonia. So if this is noticed at home, this is something that's important to tell your medical team about so that they can do a swallow evaluation where you drink a little bit of contrast and they look on radiology imaging to see how that passes through, to see if there's any difficulty with the food going where it should be or the drinks going where it should be. Uh, Very often this does progress as the disease itself progresses. And so there may be discussions about placements of feeding tubes on a temporary basis with an NG tube in the nose, nasogastric tube, or a gastrostomy tube in the abdomen and leading to into the stomach. And that is always a risk benefit discussion, and really important to include a dietitian in the medical team to talk about the pros and the cons to make an individual decision. We talk about speech therapy evaluations. I recently had a small child that parents were their most distressing symptom was actually that they couldn't understand what their little one was saying. And so we talked about getting a referral to speech language pathology, and in particular, augmentative communication, where they can develop communication. They have communication tools like different boards to help facilitate communication and reduce that distress. Also modifying food textures. There's additives you can add to liquids or different ways of preparing meals to make it safer. And then, of course, that good upright positioning, and not only sitting upright and supporting the trunk, but also keeping feet planted. That's something that's often not thought about, but it can be very destabilizing if you're sitting in a chair and your feet are dangling. And that actually causes more burden to maintain your control of your upper part of your body, your trunk, and can make it a higher risk for choking. So you always want to have feet well supported and kind of sitting in that good ergonomic positioning to eat is the safest way. And then again, just working with a dietitian, thinking about higher calorie options. There's smoothies and shakes. Some people are dairy people and they love a good chocolate milkshake with lots of cream and ice cream added to it, and others are not. That is distressing to their GI system. So there are some higher calorie supplements that include protein and other essential vitamins and nutrients that are available like in a juice form. So working closely with the dietitian is really important. And then other side effects, you can see some fatigue, skin changes. That is something that the radiation oncology team is really good about having to troubleshoot. They have special creams and lotions if there's breakdown in the scalp from the radiation treatment. And then fatigue is just allowing rest. It really is. The more you rest, the better your body is able to heal. It is so important, and something I often do counsel people about is it's okay to rest. It's important to rest, and rest is going to often get you back on your feet faster in that regard. And then the steroids alone have tremendous side effect profile. The appetite can be raging, and you can develop significant sleep disturbance as well as irritability. So you end up with, if you have, say, a child who is 6 who has a DIPG, a diagnosis of a DIPG, that they're very cranky, very hungry, and not sleeping, which means everybody else in the house is also cranky and not sleeping. And so these are things to communicate with the team and also think about working to wean down the dose of steroids if these side effects are difficult to manage. Focusing on those high calorie foods, things like good olive oil and avocados and things that offer good fats, healthy fats that are very satiating can help. Making sure that there's also good nausea control and good stomach protection with acid blockers, because steroids can certainly irritate the lining of the stomach. The mood changes. Sometimes there is a need for medication. If they're extreme, it generally gets better as the steroids are weaned, and a lot of trying to do distraction with whatever gives yourself or your loved one joy, journaling, walks, movies, games, whatever is fun. And then avoiding sick contacts, especially during cold and flu season. We always encourage participation in normal activities to the extent possible and desired, but maybe thinking about wearing a mask, or if you know someone is sick and they're wanting to come visit you, asking them to kindly stay home until they feel better. And then just briefly going through quality of life. In terms of daily living, comfort, there's a lot of times I think maybe a hesitation to ask for things or advocate. And that is what we as nurses really try to encourage patients and families to do and to say. When we say, is there anything we can help you with? We want to know are you carrying your loved one to and from the bathroom and they weigh 90 pounds and your back is hurting and there's an unsafe situation? Do we need to try to source a wheelchair, a walker, a Hoyer lift, something for the home to make things safer for you? These communication boards, as I already mentioned. For children in particular, but I would argue for anybody with this diagnosis, routine and normalcy are paramount, to the extent possible, just to feel some semblance of control back when so much has been removed. And whether that means participating in school via Zoom, getting a Chromebook to do homework, or going to your job on maybe a part-time or modified basis, or working remotely, even some measure of engagement in things that were more typical to your day-to-day prior to this diagnosis can be so therapeutic during this time. Integrative therapies as well. This has really become part of the forefront of care, I would say, especially in the last decade, whereas we commonly encourage non-pharmacologic ways of managing these symptoms. So we think about music therapy, art therapy, massage, pet therapy, and integrative health. There's many oncology centers that actually have integrative therapy teams or clinics. So that's something to find out about at your particular center. To ask, is there someone that can consult with me who may have expertise in these therapeutics? Do you have acupuncture available, massage, Reiki, other things that, again, can just provide profound healing in ways beyond the medicines that we have available to us? And then we never forget about the emotional and spiritual aspects of a person. As nurses in particular, we're always taught to consider the person as a whole entity, and all the more so when they are facing a serious illness. One of the ways in which we think about that is engagement with a palliative care team, whether that's community-based through a hospice program, whether that is in the hospital or clinic setting. But the palliative care team is an interdisciplinary team that will think creatively with you along the way to try to troubleshoot these symptoms and try to make sure that all of your needs are being met, mind, body, and spirit. Counseling, social workers are incredibly valuable in helping families process what's going on and being that listening ear, that emotional support, as well as helping them to access concrete resource needs, especially with difficulties many families are experiencing with sourcing food. This is all the more reason to never try to suffer in silence and speak up, because there are resources available to help support families. Support groups. There's a multitude of wonderful support groups that support patients and families with diagnoses of DMG. There's some that meet monthly that we often inform families about, and then spiritual care providers, chaplains, and others. And then working effectively with your team. So this is probably just review common knowledge, but the way this works is the ideal is that everyone is working together in concert with each other and that there aren't efforts being done in parallel. And so as nurse navigators, that's something we try really hard. I sometimes feel like we're, an air traffic controller in that regard, making sure that the bigger picture is always kept at the forefront of the mind and that we're meeting all of those, again, holistic needs of a patient and thinking through, do we need to pull in child life? Do we need a physical therapy consult? Do we need to get speech therapy involved? And communication. One thing I've always told families that are newly diagnosed with any cancer is to bring some sort of journal, whether it's a notes app on your iPhone, any sort of document, any way that you can document, write down questions, and keep it with you. Keep it in your purse. Keep it at your bedside table. So if you wake up at 3 a.m. and you're like, what about this? You just write it down. And that is really helpful. And you bring that with you to your medical appointments with your oncologist. And so you're not having to try to retroactively kind of remember what you're concerned about. Symptom diary, especially for headaches, can be very informative to help troubleshoot. And if not eliminate them, at least make them more tolerable, at least help you to engage in your day-to-day life. And honesty. I would say this is especially with regard to any supplements or all alternative therapies that you're interested in or maybe wanting to give or do give. There's actually a risk for significant toxicity with some of these therapies that if we don't know what's being given could cause harm. And so we want to make sure we just know and give the pharmacist or the dietitian a chance to check those supplements to make sure that they're safe. And then ask clarifying questions. It's your body, it's your life, you're the patient or it's your child or your spouse, your loved one. Ask questions, and I empower you always to do so. All right. So, and then resources, lastly, so our program is funded and run by the Chad Tough Defeat DIPG Foundation. I am honored to lead it. We are the leading funder of research for diffuse midline glioma, as far as we know, in the world. And we are a team of myself. We have 4 full-time nurses and a wonderful social worker who are available to patients and families throughout the United States to provide just longitudinal support. We offer flex scheduling and sort of our institution agnostic. We are here just as a resource and support. We all have expertise in this disease and can help you with many of the things I just mentioned in terms of what to bring to your oncologist with questions and resources. And we have a lot of connections to phenomenal physicians like Dr. Koshman to help you get the best guidance and support for the diagnosis. So this is my contact information, and I thank you so much.
Oh, Bree, I think you're muted.
Thank you so much, Dr. Koshman and Daniela, for all the amazing information you all shared. We are going to share the slides and a resource handout along with this recording afterwards. So that will be coming your way in an email before the end of the week. I've been following the questions as they've been coming in during the presentation. So I'll start there, but keep adding your questions to the Q&A section at the bottom of your screen. If you've got more, we'll answer as many as we can in the time that we have. So our first one is from someone who has a DIPG with the H3K27 mutation. They're currently 39 and they're wondering why there is an upper age limit for many of the DIPG clinical trials.
That's a great question. And quite honestly, prior to age 39, forever, it was 21 or 18. And a lot of that came from a logistical constraint of a lot of these trials are being built out of children's hospitals, and they just simply they don't take patients over 21 because their providers aren't credentialed for that. I think knowing that DMG is not just a disease of childhood and teenage, that we have these patients in their 20s, 30s, 40s, and beyond, I think has pushed us as clinical trialists to expand that. And I think the reason that clinical trials make any rules at all is to try to make the patient population homogeneous. And that's helpful from figuring out whether the trial works in a patient population. I think the thought process behind age 39 was you're at least getting patients who are generally not elderly, but that doesn't make much sense to you as a patient that just turned 40. You're now older than you were, from a medical perspective. But the idea is to take younger, healthier patients and have a homogeneous group rather than to include some 60, 70-year-olds, which are rare. And you will capture the vast majority of midline gliomas. But for families that turn 40, or for those that are trying to get on a trial and they're 25 and that center stops at 21, this is extremely devastating. So we're certainly advocating for being more inclusive. I myself have started taking care of patients with midline glioma into their adulthood, but that does become complex when patients go to different hospitals for ER care. Some nurses and infusion centers aren't able to do that crossover. There is a movement in oncology towards this adolescent young adult where providers are being trained right now to take care of patients as children and into adults, kind of like a family practitioner. And so I think we're going to get better at this, but I don't have a short answer. The only other thing I'll say, and then I'll see if Danielle has a comment, is some of the trials, including the Stanford CAR T, has opened even to older than 39, as I understand, past like up to age 60 or something. So I think there is movement towards inclusion, and obviously things off trial are much less restricted.
Yeah, I don't have any further comments, but we are seeing a shift where there has been a broadening of age ranges for inclusivity in these trials, and we're hoping that will continue. And we certainly, as nurses, try to advocate for that as well.
Thank you all. Our next attendee is someone who has an H3F3B mutation, and they're wondering how you differentiate DMG from a high-grade glioma in that situation or when other mutations are involved.
The H3F3B is extremely rare, and I think it's found in some adult spinal cord tumors. There's just a paper published about these tumors, and I think their biology has some overlap, but also clearly its own. We need more patients with that tumor biology to be described to be able to answer a little bit more coherently. I think in general, we would say they're closer to midline gliomas than high-grade gliomas. They do have that loss of trimethylation, and probably the clinical trials and treatments for the standard histone mutation would be the most promising. But again, it's a subgroup that's a subgroup of a rare tumor, so it's hard to answer more confidently than that.
Yeah, absolutely. Understandable. Our next attendee is wondering, how do you know if you have the MAPK mutation or really any mutation for that matter?
Yeah, so Daniela and I are big proponents of having tumors molecularly profiled. And what we mean by that is when the tumor is biopsied, the first thing you get back in that first week, and really what's done everywhere, is histology. They're taking a slide of that tumor, staining it for things you can stain for the histone mutation, and then giving a report. This is a midline glioma. It has the histone mutation. It doesn't. That's about as far as they go. There's a couple other stains. That is short of sequencing. A molecular report or a sequencing report is that same tissue is sent and sequenced. And there are a lot of different, some academic institutions offer sequencing. There are some, sort of private, like you mentioned Caris in this question, but other sequencing groups, and that's all going to be sorted out at your institution. That is really, we think, I would say, should be standard of care, that the tissue is sequenced, and you should get a report. That's going to take you usually 2 to 4 weeks. That report should come to you as the patient, and you should have knowledge of what are the main mutations. Should be somewhere between 1 and 10 mutations that are the signature of that tumor. That's how you would find out the MAP kinase. The main ones are BRAF and FGFR1. But there are some others that are being considered, one of which is KRAS and NF1. This is a newish thing. We found this MAP kinase group in France found the same thing. So we think it's real. And I think hopefully in the next few years, the WHO will start to tell you in your diagnosis, you have an H3 mutant / MAP kinase. So it's a little easier to find that out.
Great. We've got time for one more, and this is a pretty simple one. Is DIPG generally a pediatric or an adult tumor cancer type?
Danielle, you want to take it?
That is a great question. In general, so DIPG is now more of a colloquial term. The WHO, the World Health Organization, reclassified brain tumors several years ago. And so now DIPG is formally in the medical diagnosis. So you may see this in your chart, if you're accessing your My Chart, that it is actually a diffuse midline glioma of the pons. To answer your question very simply, is that it is predominantly seen in children, typically around ages 5 to 10. So in that elementary age, which is a time of tremendous brain growth and development. It doesn't have a direct causation as far as we know. Like Dr. Koshman mentioned, we don't have a direct cause for this diagnosis, but something that is of note and worthy of further investigation. But it is a pediatric predominantly disease, although we've supported quite a few patients in their 20s and 30s that have disease in the pons as well.
Thank you so much. As I mentioned earlier, everyone on the call will receive the link to the recording in a follow-up email along with the slides and the resource handout. We also want to hear from you. Your feedback is not only helpful to Dr. Koshman and Daniela, but it also helps guide our future programming efforts here at the ABTA. We're all ears on anything you'd like to share, the good, the bad, the ugly. All you need to do is just scan that QR code on your screen or go to the link that's listed there. It should only take about 5 to 7 minutes of your time, and it really, really means a lot to us. Our last webinar of the year will be held on December 10th at 1 p.m. Central Time. Elise Heidelberg will be presenting on brain tumors and the holidays, a very timely topic. The holidays can be a difficult time for brain tumor patients and their families. Cherished memories may feel different. The emotional impact of illness is often magnified. And so during this webinar, we're going to discuss strategies to cope with the emotional weight of the holiday season, honor past traditions, and also create new meaningful ways to celebrate. So whether you're dealing with loss or just struggling with the new normal, this webinar is going to offer support and understanding to help you find comfort and connection during the holidays. Registration is currently open, so I hope to see you there. And if you're looking for more resources from the ABTA, visit our website at abta.org, email us at info@abta.org, or call the ABTA care line at 800-886-2282. Thank you again to Carl and Daniela for a fabulous webinar, very, very informative. Thank you to today's webinar sponsor, Chimerix, a Jazz pharmaceutical company, for your support of this program. And a special thank you to each and every one of you for joining us today. We hope you found this information useful and make it a great day.